All right, here we go.
So my name is Emily, and I'm the pharmacy resident for this year. Almost done here at the end of June. But I'll let Allie introduce herself as well.
Hi everyone, my name is Taubenheim. I am an RN at Kook.
And today we wanted to talk a little bit about my residency project, which was working on metabolic monitoring in patients taking antipsychotic medications. And I thought it would be really helpful to have Allie join me today because she was really instrumental in actually doing the work and implementing some of the things that we talked about.
Thanks, Emily, for having me.
All right, so the objectives are going to be to discuss the recommended metabolic monitoring parameters for patients who take antipsychotic medications, explain the importance of completing this monitoring, discuss residency project results, and review 3 Kook patient cases. So first, I'll share a little bit of background on why we think it's important, and then I'll ask Christina to share a little bit of perspective about some of the projects that were going on before I came on as a resident that this one was meant to try to sustain a little bit. So first, this slide, I wanted to highlight the overlap between mental health and medical conditions. So 29% of adults with medical conditions also have mental health conditions. And then conversely, 68% of adults with mental health conditions also have medical conditions. And the presence of comorbid conditions can also lead to suboptimal patient outcomes. It's been shown that individuals with mental illness die younger than people without these diagnoses, but they're from the same leading causes of death like heart disease and cancer that are most common nationwide. So individuals with serious mental illness die on average 25 years earlier than the general population. This might be the poor outcomes that these patients more commonly have might be linked to lack of appropriate care. For example, one study found that almost a third of patients with schizophrenia did not receive appropriate medical treatment for their diabetes, and 62% and 88% respectively didn't receive the appropriate treatment for both high blood pressure and then high cholesterol. So Christina, if you're willing, can you share a little bit about the projects on this work that were going on previously and why you thought this would be a good project to do now?
Yes, of course. Thanks, Emily. Yeah, with integration and kind of what Emily is talking about the comorbid medical and mental health conditions together. Kook has done a lot of work over the years with furthering integration between different departments and different disciplines. And specifically back in the early 2000s, there was some work done more on the infrastructure of the building to bring towards some integration. And then, there were pros and cons and good and things that didn't work out so well with that process. And then again, in about 4 or 5 years ago, Kook was awarded a grant through SAMHSA and HRSA, which are kind of the federal bodies that do work with mental health and do work with primary care clinics like Kook. And so with that grant, it's really to bring together and look through a more whole person lens on the patient, with the patient and their work. And so some of that was doing some more intentional screening of patients who have a mental health diagnosis, do some of the screenings that are more about their physical health and engaging them into primary care services, which luckily we have on site. And so with that, part of our work there was to develop a sustainability plan. So once the grant goes away, then what do we do? And so both with the health record transition and also the transition of that grant, this is a great opportunity for Emily to engage in this work and build a workflow and a plan with our new health record and with that grant going away, something that is sustainable and evidence-based and really looking towards all teams to contribute to it. Thanks, Emily.
Thank you, Christina. So before we jump into what exactly we did, I wanted to give a little bit more background. So there are a lot of guidelines around what monitoring patients who take antipsychotic medications should have done. So these are some consensus recommendations from the American Diabetes Association, American Psychological Association, Clinical Endocrinology, and the North American Association for the Study of Obesity. They recommend that at baseline, prior to starting or changing antipsychotic medications, patients should have a personal and family history completed, have weight and height measured, as well as waist circumference, blood pressure, fasting plasma glucose, and fasting lipid profiles. And then at follow-up, it's recommended to reassess weight at 4, 8, and 12 weeks, and then quarterly thereafter. Glucose, lipids, and blood pressure should be reassessed 3 months and then annually thereafter. If it's a normal lipid profile, you can consider relaxing that repeat testing to be at 5-year intervals, but if there's anything abnormal or other reasons to check it more frequently, then of course that is supported. So why is this monitoring recommended? Antipsychotic metabolic adverse effects are well established, with rates of metabolic syndrome between 23 to 50%, weight gain or obesity between 6 and 55%. For type 2 diabetes, rates are 2 to 28%, and dyslipidemia rates are between 15 and 53%. And this table on the right here is just showing what some of the more common offenders of these adverse effects can be. Additionally, there in the literature, it's pretty well documented that these screening practices are difficult to implement across clinic settings. There's some potential reasons are proposed, including a lack of awareness of what monitoring should be done, unclear responsibility of who should be doing the monitoring, and difficulty collaborating between primary and psychiatric care, as well as the severity of some of the psychiatric conditions that are being treated. So the literature has looked at a variety of interventions, including provider education, targeting patients, and improving the systems in which this work is done. Previous quality improvement projects have also been done working on improving these rates, and a project in 2015 showed improvement in monitoring rates by 20%. So given that information, the aim of the current project was to increase compliance by 20% for clinically appropriate monitoring in COOP patients on long-acting injectable antipsychotic medications by March 15th of this year. So now I want to pause and ask Allie if you'd be willing to share a little bit about what was done kind of before we started talking about this.
Yes, Emily, that is a great question. So what I will say in a few moments is what we still do as nurses, but later on this presentation, we will discuss how our role in this process has changed to meet the monitoring parameters. Nurses are very methodical in our process of medication administration. Nurses are trained very well to do it the right way. And specifically with LAIs, we do a lot of care coordination to get the LAI delivered to the clinic by Genoa Pharmacy. We ensure that there's an active order on file from the provider. So then the patients will come to the clinic as a nurse-only appointment every 14 days or every 28 to 30 days or every 3 months, depending on the medication that's prescribed. We follow the 7 rights of medication administration, which includes the right patient, the right medication, the right dose, the right time, the right route, the right reason, and the right documentation. During that visit, we'll also check in with the patient and perform a mental status exam and ensure that they have adequate follow-up with their primary psych provider. And then we'll walk them out and get them scheduled for their next LAI appointment.
Thank you. All right, so then for the project, I started with reviewing the existing metabolic monitoring protocol that was in place at COOC and updated a few things, specifically or most of what needed to change was just that the EHR changed from EHS to Epic now. So there are a few things to tweak there. And then I completed a baseline chart review in order to review when all of our patients who received these medications last had an A1C and lipid panel obtained, and then when each of the vitals, including weight, height, waist circumference, and blood pressure were last collected as of January 1st of this year. Then I attended some different meetings, including the clinic-wide meeting, a nursing huddle, and a psychiatry department meeting at the beginning of the trial period in January to provide some initial education on what these monitoring parameters are recommended to be, and talk about how we can improve what our current workflows are. And then at the end of the intervention period, which ended up being about 2 months, charts were reviewed again to assess progress in completing all of those recommended parameters. And I also looked at some additional information, such as patient race and ethnicity, who their primary psychiatry provider was, and whether or not if the patient received primary care at COOP, to see whether or not those things might have played a little bit of a role in how likely they were to have all the monitoring complete. So to summarize some of what I found, we had 55 patients with active long-acting injectable antipsychotic medication orders. And at baseline, none of those patients had received all of the monitoring. And then we knew that waist circumference was not being done. So excluding that, looking at all the other parameters, 10 of those 55 patients had received all of the rest of the monitoring, or 18%. After the intervention period, that changed to 13%, or 13 patients out of 55, which ended up being 23%, that had received each of those monitoring parameters, including waist circumference. 8 of these patients received primary care at COOP, and additionally, of the whole 55 patients with these orders, 10 of them met criteria for metabolic syndrome. 5 of the patients of those patients who meet the criteria for metabolic syndrome had received all the recommended monitoring. So the other 5 did not have everything up to date, but still met the criteria for metabolic syndrome. Here's a breakdown of patient race and ethnicity according to their chart, of the 55 patients, and broken down based on what percentage of those patients had up-to-date monitoring complete. And I also looked at their primary psychiatry provider to see how many patients they had on this panel, and then what percentage of patients received up-to-date monitoring. So that's what this table is showing. So again, I want to pause here and Allie, ask you what surprised you about the results?
Well, first of all, I was really surprised that we met the project aim in such a short amount of time, with just about 2 lead nurses implementing the protocol primarily. Out of the pool of 55 patients, 10 met criteria, which is 18%. And of those, of all recommended parameters, 5 out of 13, which is 38%, had metabolic syndrome. So that was surprising as well, that the number was so high. And the results also show room for improvement, and just how prevalent antipsychotics can cause serious chronic conditions. You know, when we look at these results, it feels kind of steep, but you know, there's a lot of work to do. But with that, you know, we rise to that occasion, and you know, this really matters, and the numbers show it.
Thank you. So looking at some of this, I think it's clear, like Allie said, some of the positive impacts include that the project aim of increasing clinically appropriate metabolic monitoring by 20% was met, which happened in a very short amount of time, and was driven by a couple of key staff members. And I think that's consistent with previous literature. And so that's great for us to know that these efforts are really making a big difference. It also showed the impacts of being able to improve how we coordinate our care. And it was, I'll let Allie share a little bit more about this, but it was well received by patients anecdotally, this increased efforts. So I think that all of that shows some of the positive impacts of this work. There were obviously some limitations. COVID-19 changed workflow very drastically, with psych care being primarily, if not completely, remote for some time now. And I hope to mitigate that to some extent by focusing on patients who receive injectable antipsychotics, thinking that they'd be coming into clinic at least fairly regularly for those injections. However, some patients do receive their injections at their group home or by home health nurses or at the pharmacy. And so that didn't totally capture it. Additionally, these patients, our patients at COOP, often travel. And so there were patients who were out of the country for this time period. And so obviously couldn't be targeted for getting these monitoring parameters done. And there are obviously time constraints. There are many different priorities for patient care and only so much staff to get everything done. And so that can make this challenging. There could have also been some selection bias in seeing which patients agreed to have the monitoring done, and then by focusing on this patient population specifically. So Allie, can you share what your experience of implementing the protocol was like for you?
Yes, Emily, thank you. So Emily has highlighted some of it, but the challenges I think for the nursing team was that we really were starting at square one with appropriate drug monitoring parameters for every single patient. Therefore, it felt pretty time intensive, just because prior, when patients would come in for their injection, it was a very quick exchange. And so a lot of patient education had to be done around this. And when we would talk to patients about this, they didn't really understand. And a lot of them mentioned that they didn't really know the effects that their medication had on their health. Also, some of the other challenges was that it felt like a pretty siloed effort. I think that there was a lack of clinic-wide buy-in. And also there was some worry from nurses, and specifically, we had conversations and questioning like, can we rely on timely response from the patient's care team if the patient's lab values come back remarkable and require timely follow-up? And so it was a whole new level of responsibility across the whole team and across departments, which I think highlighted a lot of the challenges. And then to speak to some of the positives, I will say it was very rewarding because when you're a clinician and you're meeting quality care and national standards of practice, it feels really great, but most of all, we're improving patient outcomes and you're resurfacing chronic conditions that are completely unmanaged and uncontrolled. And like Emily said, patients were very, very receptive to the various interventions of this protocol. I had patients that became very enthusiastic that I was even talking to them about this, and they would make comments of like, oh, nobody has ever talked to me about this before. I would really like to find out more about this. I want to know what my lab values show. And maybe they had been told about this in the past, but this is in a new way at a different time. And I just think it highlights that RNs can be very successful at implementing appropriate drug monitoring. We work really hard to build a strong rapport with patients. We see them frequently, monthly, or even every 2 weeks, and they grow to trust us. And so it really showed to be a successful implementation among nurses with the LAI panel management.
Thank you. One thing I wanted to spend a little bit more time talking about is waist circumference, because that was a barrier prior to and throughout the project. And I just want to highlight that the research really demonstrates the importance of measuring waist circumference. For example, a review by Koster et al. In 2008 looked at the association between waist circumference and mortality. And this was a really big study looking at about 150,000 men and 90,000 women between the ages of 51 and 72 years old. And they found a 25% increased mortality risk in the patients who had a larger waist circumference, which they defined as being in the 5th percentile as compared to the 2nd. Additionally, this increased mortality risk persisted even in patients with a normal BMI. And these patients had a 20% higher mortality risk if they had a larger waist circumference, which again defined as 102 centimeters in men and 88 centimeters in women. This association was found to be consistent regardless of whether the patients had other prevalent disease, their smoking status, and their race or ethnic group. And so this evidence just really reinforces the importance of completing this as part of metabolic monitoring in particular, or at least educating patients on why it's important so that they can make an informed decision. So knowing that this has historically been a challenge, I wanted to ask Allie what your experience of getting waist circumference has been like.
Yes, thank you, Emily, for asking about that. I feel like there might be some misconceptions about how easy waist circumference is. It's a very easy task and it just takes a few seconds. I had very little refusal from patients. And again, good patient education usually occurred around this. If patients had maybe like baseline paranoia, aggression, auditory or visual hallucinations at baseline, maybe they would refuse. I thought it was helpful if I just showed patients what I would do to them by demonstrating on myself, and then they would be okay with me doing it on them, even for those patients that would historically refuse something like this. And so, you know, just because patients may refuse once doesn't mean we stop asking. And like Emily said, this is very important. It's an important piece of data that we should look at, and we should continue to offer and advocate for what we know will improve their health outcomes.
Yeah, thank you. So now that you know, that initial focused kind of trial period is done, some of the next steps is getting the updated protocol published to the internet, which looks pretty similar to what it was before, with the SAMHSA grant required a recommended lipid monitoring frequency every year. And so I think based on that panel recommendations I mentioned earlier, it can be relaxed to at least every 5 years if everything is normal, but obviously depending on clinician judgment if it should be more often. Also, we plan to explore some clinical decision support tools like bulk lab orders or a best practice alert that can pop up in the chart. Other ways to use the EHR to help us remember and find a good way to do this monitoring. And then just continuing to review the literature and the guidelines and educating our colleagues on why this is important. Allie, do you want to talk a little bit about your nursing note template for these visits that you made?
Yes, so we created a dot phrase and epic, a dot SA124 to standardize practice and documentation efforts across the RN team. With this, we certainly had a level of standardization with our work, and it also increased efficiency. And so on the slide here, there are 2 screenshots of what our note looks like, and it doesn't take long at all to complete, but it's very comprehensive.
All right, so then what we kind of wanted to wrap up with is some patient cases of some successes that we had as a result of this project.
I'll take the first case, Emily. So we have 3 cases, like Emily said, and they're very brief, so they won't take long, but I think that they're valuable to go through. So this patient was a 44-year-old male with a diagnosis of paranoid schizophrenia. He gets Haldol decanoate every 28 days. So he came in to the clinic in February, and we implemented the intervention protocol With him, we noticed that his blood pressure was elevated at 158/100. His A1C came back at 7.6%, and his triglycerides and LDLs were elevated as well. He also has additional comorbidities of type 2 diabetes mellitus and also high cholesterol. And so when we noticed these results, just even the first day with the blood pressure, we scheduled him to come into the clinic the next day for a medical visit in February. He ended up no showing. However, because the RN staff were more aware of the patient's comprehensive health through this protocol, he finally made it to a follow-up appointment with medical in April. And so this is just a really good example of persistence and also bringing possible health concerns to the surface. And also his last primary care visit was in March of 2019 at Cook. So even though he was coming to the clinic every 28 days for the injection, he had not attended a medical appointment within nearly 2 years, all the while he had these chronic health conditions uncontrolled. So this really is a success story for getting him wrapped into medical care. Patient case number 2. So this is a 34-year-old male with a diagnosis of bipolar affective disorder. He receives Abilify Maintena every 30 days. He came in April. We implemented the screening protocol with him, and his serum creatinine came back elevated as well as his triglycerides. And so within 2 days of these lab results, I then got a message from his primary psych provider, and I'm going to read the message to you all. It says, "Hi, Allie. This patient had recent lab work, which confirmed that he has renal dysfunction. I'm not clear how the lab work was ordered. To my knowledge, he does not have a primary medical provider. Could you please contact him and find out if he has an identified PCP? If not, let's get him scheduled. Thank you." So when I received this note in basket, I called the patient and I reviewed the labs with him, and I discussed the need to probably be evaluated by a medical provider. And again, like a lot of the other responses with patients like this, very thankful and almost enthusiastic of, he was like, "Oh, I'm so glad you're calling me and you're asking me about this. I've been meaning to get established with a medical provider for so long. I just keep forgetting." And so then he did end up establishing with a medical provider that month in April. And another great thing is that he completed the COVID vaccine series in May.
For the third patient, it was a 57-year-old male with a diagnosis of paranoid schizophrenia who received Invega Sustenna every 28 days. When he came in for his injection in February, they found that his A1C was 8.5% with triglycerides of 229 and LDL of 104. So they were able to get him looped into an appointment with a medical provider in March. And before this appointment in March, he had not been seen by a medical provider since 2018. And he's had multiple follow-up visits with the primary care provider since then, kind of reintegrated back into primary care. And again, he also received his COVID vaccination complete in April. So we just kind of wanted to highlight that as, looping patients back into primary care is helpful for just the whole person care, not just for this monitoring specifically. So now we wanted to talk a little bit to kind of close out the presentation just about the lessons that we learned from some of this or from this work. We know that patients who have mental illness are not receiving, generally have less access to care. And so health equity, we know, is a key part of the COOC mission. And all patients on these medications have the right to know about what the potential side effects can be and how they can affect their health in other ways. And we think it's important to not assume that just because a patient has a certain diagnosis that they aren't interested or willing to have this monitoring done and appreciate the education. obviously patient and staff safety is important. So if either one is not comfortable with whatever the monitoring parameter was, like that's okay, but we should be offering it to all of our patients.
Yes, great point, Emily. And another lesson learned that I think is very valuable is team-based care. There's a lot of value and importance of bridging primary care and mental health care to meet the holistic needs of our patients. And we're lucky enough at Kook to have both services on site. And so when we all team well, patients receive better outcomes, which is why we do it. And really, we should weave team-based care into everything that we do, because we're a team at Kook. And I wouldn't be able to do my job with this protocol if it wasn't for the pharmacy team and the psychiatric department and the medical department. And so, and likewise, the patient wouldn't get the care that they needed either without this teamingness in the center.
And so kind of along those lines, that kind of leads into comprehensive care and how that's important. And I just want to kind of circle back to what we talked about in the beginning about how often medical and psychiatric conditions co-occur. And so that kind of really highlights the importance of this work.
Yes, and then I just want to highlight very quickly practice management. And it goes for all of us on the team. It's really figuring out next steps. So when labs are abnormal, there's a lot of people that we can consult with, a lot of different people to pull into the patient's care team. Like we could consider referral to dietitian. We could schedule the patient with one of our pharmacists. We could involve one of the RNs on the team for care coordination. And again, I do it a lot, is looping in case managers. And again, the consultation between psych and medical is essential as well.
So with that, here are the references that I used. And then we can take any questions that anyone has, and our email's on the slide here as well for people to reach out later if anything comes up. And I also wanted to take a second before we move into questions to thank the nursing team at Kook for all of the efforts that they put into this work and just how much effort they put into taking care of these patients in general. I think they were the key drivers of that improvement that we saw in a really short amount of time, which is very impressive. And also the pharmacy team, my preceptors at the clinic, I wanted to also thank them for their guidance in the project. So now we can take any questions. Brittany Kimball says yes to team-based care. Thank you.
Yay.
This is Christina. I would thank you both for presenting. One piece around the waist circumference that I did just want to mention is that, the way that the flow used to work, some of the challenge was it being done in the hallway and in a more open area. And so that was one area that we did seek out consultation from our patient advisory team on a couple different items. One of them being waist circumference, another one of them being SOGI or sexual orientation, gender identity information, and patients overwhelmingly gave us the feedback that they wanted it. They were okay with it all being done, just doing it in a private space. And so that's another piece of information that I think helped to make this a little bit more successful. And so I just wanted to mention that part of it too.
Yeah, that's great. Thanks, Christina. That is a really important part. The privacy part with patients is a key to the receptive part of it.
There's also a question in the chat. Do we have pictures to show patients what waist circumference is? I know you mentioned that you'll demonstrate on yourself, Allie, but is that something that you guys have? a picture?
I've never shown a picture to patients with how it is to be done, but that is a good idea. I assume we could probably Google a picture really quickly and show a patient on the computer. Yeah, that's a good idea.
Yeah, I agree. I can, we could even find a picture and print it and laminate it to have in the room, or look into other ways to. Yes,
Video
or
options as
video
well.
options.
Yeah.
We could bookmark some video options too that could be, well, that's a good suggestion. Thank you.
Yeah, that is the experiential learning with our patients that we try to engage into. Yeah.